there we go. So this question is kind of valid right now because of the fact that we're kind of low on PPE, that, you know, we're starting to get into some of the older stuff. The only stuff really that we can guarantee doesn't have latex in it is gowns. The masks even had latex in the ear loops lately. So be careful if you got latex allergy. That was just a fun one. Oh, so far, there we go. We got some points. Let's go on to the next one. Oh, wow. Welcome, Paris. You can go ahead and join then if you get a chance. All right, so I got 3 of you said lisinopril. All right, so let's just look at these real quick. And again, these are kind of really, these are the generic names for most of this stuff. Sertraline is what? Does anyone know what sertraline is? Different than citrulline. Sertraline is an antidepressant. Prednisone is a steroid, so therefore it's likely to do what to the blood pressure? Yeah, increase it, right? And we know just by, you know, both the plazas and the bisons in our class, we know what caffeine does to blood pressure, right? Caffeine increases blood pressure. All right, so let me take a new screenshot here since I saw that Paris showed up here. That way I can validate she's here. There we go. Move that over here for storage for later. Get out of my way. There we go. Go over there. Thank you. Out of my way. Back over to the other screen. All right. All right, so we got ordinal, we got nominative. Good. Well, at least don't pick descriptive. That's not a real thing. Do you remember what the difference between an ordinal scale and the nominal scale is? When you think nominal, think name. So it has words associated with it. So like in the gauge of a manual muscle testing, the ordinal scale would be the 0 through 5. The nominal scale would be the what? What would the nominal scale for that scale be? You guys remember what else you could label those as? Where you have the poor, poor minus, poor plus, good, good minus, good plus, those type of things. That would be the nominal scale. The ordinal scale is typically number-based, right? So that means, let's say something like a and oh, it's a good idea. Thermometer. Would a thermometer be ordinal or would it be nominal? Yeah, it would be ordinal, right? Now, if we said freezing, warm, mild, cold, that type of an idea, now we've gone to nominal. That's on fire. All right, so, all right, we're all over the place here. So remember, when we do any type, orange, my guess, anytime that we do lymphatic drainage, the first thing we have to clear is the trunks or the ducts. Yes, Chris, N equals name, right, exactly. So when we clear, the first thing we do, if I've got swelling, I've got lymphatic swelling in my arm, the first thing I've got to do is go up here in the armpits and clear out the ducts. Why do I have to clear those out first? And not ducks like quack, quack, ducks like, you know, what Bruce Willis crawls around in Christmas. Because if I don't clear those ducts out, anything I move from the lower part of the arm, yeah, it can get stuck and move back to the heart, right? So I've got to clean those out. And then I start pushing the stuff, right? Distal, moving proximal. Because now if I push it up, it'll actually empty back into the ducts. I miss Kahoot noises. All right, so what are our two abbreviations for this? Do you remember? There are two spin and snout. Good, right? So, and yep, that's fine. That's why I actually had a question about this yesterday with one of the students I was working with, so that's why I added it to this, right? So if a test is specific and it's positive, it rules things in. If it's sensitive and rule is a negative, it rules things out. So spin and snout are the kind of the things to remember. What if I have a specific test and I get a negative result? What would happen if I have a specific test and I get a negative result? Does that mean anything? So this test is 0.95 on specificity, and instead of a positive result, I get a negative result. Doesn't really tell me anything, unless my sensitivity is high too. So if I have a specific test, one is high in specificity. And again, high in specificity, most times you're talking 0.8 or higher, so 80% or higher. If it is high in specificity, if you perform the test and get a positive result, you are ruling the condition in, meaning the patient probably has whatever you're testing for. If the test is sensitive, highly sensitive, again, a sensitivity of 0.8 or better. Right, so that's okay. So let's say I have a specific test and I get a true positive on it. What does that mean? So let's say I'm testing for supraspinatus impingement. And I get a true positive on supraspinatus impingement and my test is specific. That means what? I probably have supraspinatus impingement, right? A true negative would have to come along the lines of a sensitive test. Does that make sense? So in order to have a true negative, I've got to have a sensitive test. Because technically, if I have a test that's, say, specificity here of 0.95 and sensitivity of 0.5, that means I could have a true positive, but my negative would never be a true negative because it doesn't tell me anything. That means half the people that I test are negative, half the people aren't. So specific with a positive result, the patient has it. Sensitive, negative result, the patient doesn't have it. So let's say I was doing something like NIRS. NIRS has a fairly high sensitivity, and you get a negative sensitivity. You do a negative test on me. That would mean that I probably don't have whatever problem you're testing me for. Look at Nat go. Yay, look at that. Right now, let me ask you a question. could a sciatic nerve test possibly show some signs on the anterior surface of the tibia? Yeah, it could, right? But the most correct answer there would be posterior thigh, right? Obviously, the best answer would be buttocks, because that's usually where it happens, right? But posterior thigh would be the best answer there. This is supposed to be Christmas music. This is not very Christmassy. Yeah, so what's an IPPTA mean? Inpatient PTA, yeah. So calling 911 is not going to do any good because you can't take him to the hospital because you're already there. Hello, I'm having somebody with a heart attack at the hospital. Could you come take them to the hospital, please? Right? Code blue or code, whatever your code is for your facility, because some of them are a little different. Most of them have specific codes. Be really weird to just start chest compressions, right? Just toss the patient on their back and just start doing chest compressions on them. I'll save you. All right, so the average wound care patient, the only thing we have to do is just do standard precautions, right? So standard precautions mean what? We wash our hands, right? We foam in, we wash our hands, and then we put gloves on. Because the average wound care patient, that's all it's going to take. I mean, if you're just doing a pressure injury or something like that, that's all you're really going to have to worry about. You're not going to have to necessarily glove gown and mask up to do it. Now, in today's COVID world, we might be wearing a mask anyway, and that's now starting to become standard precaution is wearing a mask. Airborne precautions mean I'm wearing a what now? Now I'm definitely wearing a mask, right? Contact precautions add what? What do contact adds? Not necessarily gloves. Contact adds the gown. Good. And what's droplet add? Face shield. Good, right? So standard, pretty much just the gloves, right? We get to airborne. We're now putting on a mask. We may have to wear the gown as well, but usually it's just the mask. Contact, now we're going glove, gown, and mask, right? And then droplet, we're going glove, gown, mask, plus shield over the eyes to protect mucous membranes. And maybe even a bouffant if you want to wear a bouffant. Yeah, in this case, it's consult a referring physician, right? Because we cannot apply that antibacterial agent until we have what? Let's say we have some stuff for it. We have, maybe we have some microbial and stuff like that. In order to use that on the patient, we're going to have a what? A prescription, right? We can't just all of a sudden start using antimicrobial stuff without that prescription from the referring doc. I like to ask the patient if they've eaten processed foods, because they probably have. Now I'm giving Bison some like flashbacks here. So remember that the P wave is the, what was the way I remembered it before? The P wave is because the first item, right? So when we do alphabetical, right? P, Q, R, S, T, right? P is going to indicate atrial depolarization, meaning the atrium is going to actually contract. Because when you think about it, the atrium can't, no blood can go anywhere else unless that atrium kind of contracts and pushes the blood. So P wave is atrial depolarization. And again, this just goes to show you the actual level that you should know is just what do they mean. Lack of a P wave could mean a lot of things, right? There's a lot of different conditions that could have lack of a P wave. Oh boy. All right, so we got no shoulder scaption. So D1 flexion, definitely not closed kinetic chain. Shoulder scaption, bicep curls. Why would crutch walking actually be closed kinetic chain? It's really no different than like a wheelchair push-up or a push-up or like a dip, right? It's really no different than those. And that would be a closed kinetic chain because my distal end is fixed or movable. Which is it? Fixed. That was a tricky question, Mr. McKeever. I didn't like that one because the crutches are moving. Well, we're not looking at the crutches. We're looking at the distal segment. Okay, so why is this a trick question? Yes, right. This question is from the APTA's point of perspective, not from a clinic perspective. So the APTA states you have to know what a grade 5 MOB is. You have to know what a grade 1 MOB is. You have to know what a grade 2. That's okay. You have to know what a grade 2 MOB is. Think of it this way. You're getting 20 bucks out of it, so have a little bit of fun. But according to the APTA, a joint mobilization is outside of the scope of practice for a PTA because it involves consistent and constant evaluative capabilities that a PT has. Now, in the real world, do we do joint mobs? Yes. Right? And maybe even in some clinics up to a grade 4, depending upon what they allow in your state and stuff like that, right? But definitely grade 5s are 100% out of us. Nope. I don't want to do those. Hold on, I'll do one. There, I just did one. First, we'll have to figure out what CTS is, Mr. McKeever. Good. CTS is carpal tunnel syndrome. Good. So what nerve is wasting? The median. Good, right? So that would be our thenar eminence. If I have wasting over here, it's going to be my hypothenar eminence and possibly my ulnar nerve. There, we had some fun with that question. I can't wait to get some of the 3 random questions I put in here. Here you thought you forgot. Good. That was a quick one, right? So waste level is about 50%. Xiphoid process is about 40-ish, right? Knee level, you're probably at like nothing, honestly. I wouldn't even think that reduces that much weight, honestly. It may be 5% or something like that. Cricoid cartilage is where? Good. Suck it up, Justin. Enjoy it. You got a high KD. Where's the cricoid cartilage? Basic anatomy, guys. Cricoid cartilage is here in the throat, right? So cricoid, or in the Adam's apple region, you're at about 90% weight bearing reduced. Good. Decrease the intensity. Remember with Ionto, the magic number is about 50 milliamp minutes, right? Remember I said something about that before? On average, that's typically what we treat patients at. So this that we have up here, 10 minutes or 10 milliamps at 5 minutes would be 50 milliamp minutes, because you have milliamps times minutes. So if they had a reaction, what we could do is reduce the intensity or decrease the intensity. What's that going to do to our time? So say we reduce it down to, yeah, it's going to increase, right? And it's going to increase coincidingly, right? So if I've got 50 milliamp minutes where I have 10, or 50 milliamp minutes where I have 10 milliamps at 5 minutes, and I swap that, you theoretically could, Chris, if that was an option. Absolutely. Yeah, you could increase the surface area of the what do you call it? The Ionto patch. But most of the Ionto patches are usually like itsy bitsy things anyway. But yeah, if that was an option, I would think that would be my second best option. I still think decreasing the intensity is my first option, because the intensity is what leads to burns. And you can get medication burns. But let's say it was increased intensity, decreased time, or increased surface area. Increased surface area then would be the best option. All right, which two can you rule out there right off the bat? Just look at the, yeah, red and green. Why? They're the same thing. Exactly. Right, so red and green are the same thing. So that means the only things you have left are yellow and blue. And you wouldn't feel it. You're right, Mike. But yellow and blue's left. And we know that at grade 2, we've definitely got some tearing going on. Some tearing with Karen. All right. So first of all, an end field classified as empty, joint amputation. Well, if we have a joint amputation, we're probably not going to be testing the end field of that joint. Just saying, right? So good thing no one picked that. Tissue approximation. What would that be? End field be? Soft. Good. Joint effusion would be what? It could be firm if it's really heavy joint effusion. Okay, I could give you that. What's typically the end field for swelling, severe swelling? It's the odd one. Boggy. Right? Boggy is where you're kind of moving stuff around. And you can see the fluid kind of moving in the joint surface. But pain is definitely one of those where, and that's where you're, okay, I'm going to test your elbow out. And you get here and you're like, no, stop. Well, that's not an end field. Okay, first of all, we have to figure out what is APL. Because I'm pretty sure that was what most people were worried about right there. What's APL, guys? Does anyone have a clue? I don't know. Abductor pollicis longus. Now, this is where Mr. McKeever was kind of mean on this question. Because radial nerve is correct. But posterior interosseous nerve of the radial nerve is more correct. So that would be one where I'm hoping that you guys got down to those last two and just picked the wrong one. I'm hoping that no one picked ulnar nerve. I'm happy there. And I'm hoping whoever picked median nerve just didn't know what APL was in the first place. And we'll just go with that. Good. Descending are also known as, yeah, green. I know what you're getting at there, Dustin. Descending are also known as what type of tracts? Motor tracts, right? So they will always start somewhere in the brain, so cortico, and go to the spine. That's an easy, cheesy way to figure that out, right? If it says spinocerebellar or spinothalamic or spinoolivary, it means it's going from the spine to the brain. Like a vestibulospinal nerve would be going from the vestibular system to the spine. Oops, I went too clicked. This was a follow-up to a previous question, wasn't it? Right, so if we're dealing with these three fingers, we're median, and maybe even half of this finger. If we go out here, now we're dealing with what? We got to the pinky and the ring finger, now we're dealing with ulnar, right? Typically, we don't think of radial until we're kind of back here. This is to see how many people were paying attention to Dr. Reston's class. All right, so we can rule out boutonniere and pseudo-boutonniere. Because what do you think is going to be unique about them? If I have somebody that's got Parkinson's and it has pseudo-Parkinson's, they look what? The same. Yeah. Right? So if I have somebody that's got a boutonniere or a pseudo-boutonniere deformation, they look very similar. So that means those can't be the right answer. So that leaves us then with CTS or swan neck deformity. And we know CTS has nothing to do with really the way the fingers kind of contract up. Well, I mean, it can, but not in this case. This is a very specific case. So that would be the way I would answer this question. If I had no clue, I'm like, flexed MCP joint. So flexed MCP joint, hyperextended proximal IP joint, flexed distal IP. So I kind of look like this. Like flexed. There we go. I can't even get it because my fingers won't do it. There we go. Yes, kind of like your fingers. Exactly, Chris. You do have a little bit of swan neck deformity in your fingers. Actually, it's a really good example. But does that make sense how I would have answered that question by going, oh, well, boutonnieres and pseudo-boutonnieres got to be pretty similar. So they can't be the answer. Carpal tunnel doesn't make sense. The only thing I left is swan neck. Dr. Vreskin will be proud to know that somebody got that one right. Or at least guessed it right. Nat jumps in the lead again. I know. Well, that's why we're doing it quick. Okay, so from armpit to seating surface, we get 18 inches. And you remember what we have to subtract from that? Because obviously you can tell with the blue answer. We subtract what? 4. Why? For clearance of the what? Scapula. Good. The clearance of the inferior angle of the scapula. And if you ever forget that, just think about how big that scapula is and go, oh, it's about 4 inches. Now, let's say I changed this question a little bit and I said that you measure from my seating surface to the base of my axilla and get 18 inches, but you know I'm going to be sitting on a 2-inch cushion. Does that change the measurement? Yeah, because now you have to take into account the cushion, right? So now you're talking 20 inches, right? So you've got to take into account that cushion. What's the other term for Rhineck? I call that on purpose because it's an older term. Babies get it. Torticollis. Right? So that is tightness of which muscle? I know I was mean on that one. Good, the SCM. Right? So if I'm like this, right? So it's right SCM tightness. I'm going to be like this. In order to stretch this SCM out, I've got to rotate the opposite side and bend away from it to stretch it out, right? And these are Mr. McKeever questions, so don't totally rule them as board questions. Oh, here we go. Here's one of my random ones. Come on, somebody should get this one right. Hey, one person got it right. Yes. I love how absolutely nobody guessed the New York Jets, and that's probably a smart bet. The only team to ever pull a flawless season was the Miami Dolphins. They never will, exactly. Does anyone know what year it was? I remember it, but probably none of you do. 1972. So before you guys were even, no, it wasn't Dan Marino at that point. It was Bob Greasy at that point. And the no-name defense. Ironically enough, Dan Marino never won a championship. He just has a lot of steakhouses now. Okay, so let's talk this. Who establishes the guidelines? If that was the question. Who establishes the guidelines? The APTA, right? Does CAPD really have anything to do with our performance in the clinic? CAPD only regulates who? Me. CAPD regulates educators. Right? So CAPD's out. The FSBPT's only job is to do what? What's their only job? No one picked that one. The exam, right? So you're down to the APTA or the state board. So determining specific duties within the guidelines is the state board. So that would be like saying the APTA says you can't do joint mobilizations, or you shouldn't be able to do joint mobilizations. And the state board goes, we're going to allow it. Because the APTA doesn't make laws, they just set guidelines, you could actually theoretically do it. Because the law says so, right? Just like the law says that techs can do everything PTs and PTAs can do. Oh God, here comes Mike. Have a nightmare. Okay, I thought this was a gimme. I was wrong. Why did I think this would be a gimme? It literally just, yeah, it says it, right? Does the P wave have anything to do with this at all? Nope. It's okay. The P wave just says it's normal. We don't care about that. We have an elevated ST segment. Look what the red has. ST elevated myocardial infarction. What do we call that in the hospital? A heart attack, right? Or a STEMI. ST elevated myocardial infarction. Right? So if you hear a patient's got a STEMI, you know they've had a heart attack. Did you hear that STEMI before, Chris? Is that why you said that? Oh. Yeah, so a STEMI is when the patient's had a heart attack. So if they're in a, I mean, yeah, that's why it's on there, right? This question here, so with the sinus bradycardia, does the EKG or ECG really have much to do with it? I mean, it does, but Really, what's the only thing sinus bradycardia is? It's a low heart rate. I mean, yeah, it has something to do with it, but that just means the patient has a heart rate lower than what? 60, right? Yeah, that's all that sinus bradycardia means, right? Atrial flutter is just when the atrium kind of flutters. What wave is going to be affected there? With an atrial flutter, do you think? The P wave. Yeah, the P wave is going to be affected because that's the atrial depolarization. It's okay. That's why I'm kind of covering. I know that Mike had a problem with these, and I was hoping he was going to be here, so I added these on purpose to give him heart attacks. Get it? Right? Supraventricular tachycardia. What's that going to look like? Ow, that kind of hurt. Yeah, it's going to be where the heart rate's all over the place, right? And everything after kind of that ST segment gets messed up. That actually hurt my finger. The microphone's hard. Oh, I missed a joke on this one. Darn it. I should have put the level of the patient's assimilation. Darn it, I missed out on that one. And there's no real nerds in here, so no one will get that. Darn it. The Borg from Star Trek. Anyway. The Borg RPE is that's when you say to the patient on a scale of whether you use Borg or whether you use modified Borg, scale of 0 to 10, with 0 being absolutely no difficulty and 10 being, oh my God, let me rest. How hard was that exercise for you? I feel like we're playing bar trivia here. Okay, what's this going to be based on? What's that rule called? The rule of nines, right? So anterior surface of the arm is worth how much? 4.5. Posterior surface of the arm, guess how much that is worth? 4.5, right? So the whole arm is 9. So this says I have a whole right arm burn and just the anterior surface of my left arm. So that means I end up with 9 plus 4.5, otherwise known as 13.5. Now, if I said both arms, now I'm at 18%. That's okay. That's why we do this. You're just freaking out because of the time. I know you. It's okay. We'll get through this together. Maybe I should host a Twitch channel every night doing this. Think I'd get a lot of viewers? I'll answer in a second, Chris, once we get this. Come on, guys. Woohoo! So Chris asked, and would be the type of pain for that burn? What are you trying to say there, Chris? Just so I can answer that, and then I'll go back to this question. I'm not sure what you're saying. Oh, what type of pain would that burn? Well, depend upon that. I mean, if that was a full thickness, probably no pain, right? Because what happens in a full thickness burn? The nerves be burnt. Yep. Right. So if it's a partial thickness, it would be pretty intense. depending upon how much that partial thickness has got down to the nerve level. So here we have our carpal tunnel, canal of Guillain, right? That would be our ulnar nerve. Could this have come, a question, could this have come from the first rib or even the scalene triangle? Yes, right? But what's the key word? It's in capital letters. Only, right? If I had it and it said down the entire medial aspect of my arm, now we could be thinking of scalene triangle or first rib. But because it says only, it's only down in here. Only the lonely. One second. Dr. Reskin just messaged me. All right. So we got between the two good ones. Awesome. Why are Ober and Lockman's out? Lower extremity. Good. Right. So that means we get the two shoulder tests left, Neers and empty can. Does anyone remember what Neers tests for? Primarily true rotational of the rotational cuff, or the rotation of the rotator cuff injuries, right? So even though supraspinatus is part of it, it's more for the true rotation of the rotator cuff, right? What's Ober's for? Hold on before we go further. Ober's is for yep, TFL IT band, good, right? Lockman's, one of the most common ones. Yeah, I was gonna one of the most common ones, athletes, right? ACL. All right, Oshkosh-Schlatters. Good. I just like the name of that one. Right. What's my key part of that question? Okay, tibial tuberosity. That's one good part. Right. The 13-year-old male. Right. That means it's starting to go through what? That puberty. And that's usually where this starts developing. If I would change that to a female, what would be the better answer? And it's not up there right now. What is it that females typically suffer at the knee? Patellofemoral pain syndrome. Good, Chris, right? PFPS. The Grinch is trying to steal the win. You guys should get this one. Because of the Q angle, right, Chris? Yep. So when I'm looking at this and I see safe, what's the first thing I'm going down and looking for? Yeah, I'm looking for. Well, I'm looking for assistive devices, right? And static movement, right? Yeah, right. But I'm going down and looking for an assistive device. Because I'm like, I know it's a boards. They're going to be putting an assistive device somewhere in there. And lateral weight shifting lunges were dynamic, right? Plyometrics, probably not a good idea. I'm just saying, probably not a good idea. They may have fun, but it may not be the best idea for somebody that can't feel their feet. So that left me with a single leg stance or a tandem standing. And the thing about the single leg stance in the middle of the room is, doesn't say anything about any assistance, right? The safest answer there is parallel bars. Even though it's got foam, it's still the safest option. Okay, so I'm looking at this one. The two I'm ruling out are red and green. I'm ruling Christmas out because those are involved with breathing areas, right? Inspiratory capacity and total lung capacity, they're getting ruled out. So then I have functional pleural space, which really isn't a thing. That's okay. And anatomical dead space. Anatomical dead space is the option there. Good. Abducted is the key word, right? Abducted is abducens. Adducted would be which one then? Troch. Good. Abducens. Okay, good. We split between them. Those are actually the two most logical answers. Good. Skill training's out because we're not doing a skill, right? If I'm just taking the ball and moving it up and down the wall, that's not an actual skill. I mean, I can't tell you how many times a day I'm sitting there doing a ball on the wall, right? It's not a skill. Agility involves what? Because agility is the opposite of or not the opposite, but goes with dexterity. Agility is lower extremities. Okay, good. The ball would be, so we would technically be working on stability, but it's a controlled mobility activity is what we're doing. Nudge, nudge, Bob's your uncle. Yay. I was like, nudge, nudge, Bob's your uncle there. Good job. Posterior sag and posterior drawer testing for PCL, good. And then if I have to tell you what lateral drawer test is, like, come on, guys. You had a question like that asks you about the lateral drawer test, you better be able to get that one right. Another odd one, just completely out of the blue. Just because I've been in a history mood lately, I just thought I'd throw a history question in. Green and blue are definitely out. Just, I don't know how much you guys know about history, but green and blue are definitely out. Those are the guys that were head of the SS. Ironically enough, so interesting thing, just Mr. McKeever's geek out history moment here. Laurie Torney is the only soldier to ever serve in 3 different militaries. He served in the Finnish Front Guard. He served in the Waffen SS when he was drafted by the Germans when they took over Finland. And then he also served in the U.S. Green Beret in Vietnam. And he actually died overseas. Just random question. Just like the name. I just like throwing random questions there to throw you guys off. Okay, so at the cubital tunnel, where's cubital tunnel going to be at? Not the antecubital fossa. Cubital tunnel is also known as your what? When you bang it. Your funny bone. It's not very funny when you do it though, right? So when you're doing a Tinel's test, does anyone remember what you do for a Tinel's test? Yeah, you tap, right? So if I was doing a Tinel's test on the carpal tunnel, I'd be sitting there tapping like this, and that would irritate the crap out of me. Just the sound annoys me. So it'd be ulnar nerve through the cubital tunnel. Yay! Dr. Johnson will be proud of that one. So many numbers. Okay, so I'm curious now that I look at this, I think I could see why you might have picked a strain. Why did those of you that pick strain pick blue? Why did you pick blue? Okay, so I got an acute. Okay, I guess if I didn't really specify acute. If I said acute, that actually wouldn't be wrong. Could theoretically do that. When I'm looking at lumbar, I'm automatically going down looking for 1 megahertz. That's the first thing. So I hope that was what the first thing you guys did. And technically, most of the time, you're going to do 100% duty cycle on the low back. Why would you probably not do 50%? Well, because honestly, 50% on the low back, you're not going to feel anything ever. I mean, some of you even at 100% didn't feel anything with ultrasound because that's just the way some of us are. So, I mean, the reason I was going to get into this is, a placebo effect, right? The more I was going to say is technically, I guess, because I said strain, you could have argued saying that, and this is exactly why you guys picked it, right? Is because you could have said that you thought I was talking about healing the tissue. So you went with pulsed ultrasound, right? That's why you picked it. Because you didn't want heating, you wanted healing because it was a strain. Exactly, right? Yeah, no, this one's definitely denial. Right? It's even a river in Egypt. It's denial. All right, some of you will get that later. How would I change that to be bargaining? What if I said the patient with end-stage ALS asks, if I do my exercises for the next 2 weeks, will I be able to go to my 4-year-old son's graduation? Now that would be bargaining, right? But if he's an end-stage ALS and his kid is 4, I mean, you're probably talking less than a 1% chance of him making it to graduation. Now, what if your patient said this? Would you just tell him, yeah, would you tell him, nope, sorry, buddy, you're dead? That probably wouldn't be a good idea, right? That would be where we come in and go, well, you never know where advances are going to come, right? So let's work as hard as we can now to make sure you live as long as you can and be as comfortable as you can be. Now, I mean, like, he could get the best treatment in the world and survive. Who knows? But we definitely don't want to be like, you're dead, dude. Good. Yeah, the only reason we can only do our best, exactly, right? The only reason I added this one is because evidently the cohort that's currently out on clinicals right now seems to be having a problem and I don't know why, understanding that as PTAs, we don't develop the plan of care, we implement the plan of care. And I'm pretty sure your class has got it, and your class definitely has it just looking at this. But Dr. Ovreskin asked me to add this question, so yes, so completing plan of care as established is definitely us. We can assist with all the other stuff, right? We can assist with the re-eval, we can assist with the eval, we can assist with the discharge, but we can't complete them. The PT completes us. They complete us. Show us the money. I don't like this question now that I read it. How about most frequently in what position? Yeah, so I've got to reword that one a little bit now that I read it. Yeah. In percussive therapy and postural drainage, most of the positions are Trendelenburg. So head down. Why would that be? Why would you want the head down for most of the percussive therapy? Yes, I can get it out. Exactly. Right? Now, there are some seated. There's about 2 seated positions. There's about 1 supine position. And then the rest are typically side lying or prone, and they're face down. Right? They're trying to get the head down. So I got to reword that one. I don't like the way that one's worded. Difficulty determining distances. Good. Most of you got it. Right. Dysmetric. Metric is used for measurement. So that would be a distance. Difficulty with distances. You guys aren't far apart. Oh, come on. One more history question. You know I got to add it. If anyone picks red, I'm going to throw this thing at them. Yeah. And Ben Franklin was born before that, by the way. But yeah, today's the anniversary of Boston Tea Party. That was on the news when I was working on this earlier, so I thought it'd be fun to add that. Yeah, if anyone had answered Declaration of Independence, that'd have been funny. But just remember, it is not appropriate ever to use violence in any form of protest where we destroy property. That's never been done in history. Good, covered and moist. And Natalia really loves when I talk about wound care and we're talking about keeping the wound bed moist. All right, somebody had this answer earlier. Good. Remember, alternating this motion, and I'm poking myself in the eye, is dysdiadochokinesia. What if I can't do it? So I have the complete inability to bring my finger to my nose. What changes? It goes from dys to what? A. Good, right, Paris, right? It would go to A, diadochokinesia. There we go. We got a few more, guys. We got this. Okay, good. Parallel bars is the best option there. Oh, I missed Mike's question. What is asthenia again? What is asthenia? Does anyone remember? Generalized what? Weakness. Good. So again, when it says most appropriate, I'm going down looking for parallel bars. Now, what if it would say, which would be the most appropriate for maximal mobility? Does that change the answer? Could be rolling walker. Good. I don't think they'd have that on there if that was the answer, but rolling walker probably the best option out of all of them, right? You could even probably argue the single point cane, right? If it's a right CVA, it's left side effect, right? So that means that the cane would be in that right side. So you could argue that, but I think rolling walker would be the best option at that point. All right, so why not right side lying? Do you remember that from? There we go. Good. Specifically, the heart compressing on the what? IVC. Yeah, the vena cava, right? So supine's probably definitely out because at that point all the weight's on mommy, right? And that's not very comfortable. Trendelenburg, that's just torture for a pregnant woman. That's just mean. I'm gonna hang you upside down. Quadruped is actually the best option there because quadruped's actually some of the ways that women are now giving birth too. Right? Quadruped plus quadruped takes a little bit of pressure off the inner organs too, doesn't it? Because now baby's kind of hanging on their own. Now it can be uncomfortable because baby's kind of hanging on his own, but it's not going to kill them. Potentially like right sideline could. Good, right? So that would be where you say to the patient, hey, do you know what your normal blood pressure is? Oh, it's normally 140 over 80. So I know I got to go up to above 140, probably closer to 200 because they're probably lying. They're probably like 180 over 90. Yeah. Before we even worry about calming the patient down, stop treatment. Right? Just discontinue the treatment session. That person's becoming agitated, whatever's happening, just discontinue the treatment session. It's better to do that with the TBI than it is to, can you just calm down a little bit? What do you think the TBI is going to do when you say that to them? You know, could you just calm down a little? I am calm. Here's a walker upside the head. And they become Snoop upside your head. Now I'll get that song in some of yours brain. Okay, is it normal to integrate by 3 months? It is. But the key here should occur by, meaning that how long does it have until it's abnormal? Right? And it's normal up to a year out, 12 months out. If it's after a year, now you're abnormal. But if it's still within that year, the child is, yeah, right. That's why I put this one in there. 3 months is completely normal, though. If they had integrated by 3 months, great. Good job, baby. But they have up to a year to integrate it. So remember, with a patient that has a AKA, which is also known as a, get it, also known as a above knee amputation. Well, actually, even if it's a below knee amputation at this point, right? They're typically going to contract up into flexion and abduction. So that means we need to stretch them into extension and adduction. If we don't stretch them, what might they never get? They may never get a prosthetic. right? Because I'm not going to put a prosthetic on a patient if their hips all contracted up into flexion. It's not going to do me any good. Good. Does it matter what the child says? I mean, sure. But in reality, the child doesn't have to give consent. The parents have to give consent. What if you're in an outpatient clinic and Aunt Judy brings little Janie to therapy? And Aunt Judy is not legal guardian. What are we going to have to do? If we want to treat them, we're going to have to do what? Call mom and dad. Yeah, right? Or a lot of times, a lot of these clinics will have an informed consent form on file so that it's usually have to be renewed. I think it's every week or something, or every time the patient comes in, the parents are in, they kind of have to sign a new form saying they agree to consent to have patients treated so that, if mom needs to send with Aunt Judy, that we don't have to call her constantly. Come on. If any of you missed this question. Good. Thank gosh. All right, let's touch something. Does anyone remember the kind of the not mnemonic, but the little rhyme to remember for when you should sit somebody down and when you should stand them up? If the head is red, raise the bed, right? Face is red, raise them. Yeah, they get up. Pale, their face is pale, you raise the tail. So lift up their feet. Good job, Chris, right? That's the good reminder. But in this case, what's the patient experiencing? Autonomic dysreflexia or hyperreflexia. They got a kinked catheter. Okay, good. So most you picked low and slow. With the other three choices, what's that likely to do to the spasticity? Typically make it worse. Now, if I just said antagonist contract, could that have been a valid option? Yeah, because then what theory am I working on? Other than PNF. Yeah, I'm working on the contract relax theory, otherwise known as reciprocal inhibition. Right? So like if my bicep is spastic and I have you contract your tricep, the antagonist, so that it hopefully relaxes that bicep. But because I said agonist contract, you're actually causing the spasticity to get worse. Oh no, mean Mr. McKeever. half and half. Good. So remember, for the difference, acute care or acute TENS is a high rate, so a high hertz, a low frequency or a low time pulses, that low pulse time or pulse width, right? Versus chronic is a low hertz, high pulse width. Good. Low, high. You got it. Good. Fair. Great job, guys. Close down a solid session here. 2 more. We got this. Good, right? At that, so one of the things, green seems like a fair option. It says discontinue and perform sensory examination. Except, when should you have done the sensory examination? Yeah, before you even started. Right now, let's say you forgot, and now you're doing the ultrasound, the patient's not seeing anything. Yeah, then it's probably a good idea to stop and check their sensation. Right? But you should have done that beforehand. So what do we tell the patient? Sometimes if they're like, well, I'm not really feeling anything, what was Mr. McKeever's magical phrase? Don't worry, it's working at the cellular level. Exactly. That works wonders. All right, we got last one. Bring it home strong. How? Look at that. Look at that. Dr. Reskin taught you some good stuff. Right? If they're not cruising by 36 months, do we got a problem? Yeah. If they're not cruising. So what is cruising, by the way? Just to make sure we are all on the same page. It's when you get in the car and you drive around the block, right? Holding on to furniture, good, right? Or holding on to mom. Side walking is a good term for it, right? So because we go from crawling to creeping to cruising to walking. Good. Let's see this winner's circle here. Somebody left because they're mad at me. Actually, Natalia probably got kicked. I like the new fancy podium. Okay, so good news is, let me see here real quick. Good news is you all weren't far off from 67%. 67% would have been about 40 questions on that. So, you know, if you extrapolate this out, that's not too far off. So good job. Let's stop share. There we are. Mute. I don't want to hear you mute anymore. So, yeah, this is recorded. Yep, absolutely. I remember to record. I missed like the first 5 seconds of me talking, but I did record it. Yes. So I will upload it. I'll also post the link to this so that you can go back and look at it again if you'd like. I'm going to edit that one question because I really didn't like it after I read it. Did that help a little? Make you feel a little? It made you feel a little better? Good, Mike. Good. That's what I like to see. So So just as a reminder, so today's Wednesday, right? Yeah. I don't even know what day it is anymore. Did anyone see that commercial with the I think it's auto buyer or whatever, autotrader.com? Cubital tunnel question. Cubital tunnel is ulnar nerve. Because it goes from the cubital tunnel to the canal of Guion or Guion's canal, and then up to the pinky. Right? So just a reminder, I am having expanded office hours. So they've actually taken, so Dr. O'Neill, Dr. Sokel, and Dr. Johnson have taken most of my work away from me so that I am here for you guys. I'm only right now teaching math and physics. That's it. So I am here for whatever you need. If there's a day where you just want to sit down with me and go over some questions and do stuff like that, please reach out to me. I'm willing, if you want to spend about an hour or two just kind of going through your Pete and talking through stuff, or talking through stuff you might have encountered on the score builders tests or whatever it is, I'm open to that. I'm gonna keep my office hours like I've had them, where I have, like, tomorrow I have some in the morning, Friday I have some in the kind of the mid-afternoon range, and then Tuesday, like yesterday, I had some in the evening. So those are always free for you to just show up. Out of the blue, you're like, oh, Mr. McKeever's open right now. I'm going to go check him out. If you need to schedule anything with me, please schedule. Like I said, the entire program has made me pretty much free. Dr. Vreskin's not very free right now because she's got them out in their second clinical. So she's going a little stark raving crazy dealing with that. You remember what she's like on her when she sends you guys out in the first long clinical. She gets a little frazzled. But I'm set available for whatever you guys need. So please, use me as much as you can. That's what I'm going to be here for. My schedule at this point is pretty much open, and I'm going to have those same hours even over that 2-week break that we normally have at the end of December, where the Christmas week and the week after that we normally have off from school. I'm actually working those 2 weeks still in order to give you guys some extra time if you need some extra help. So send out a smoke signal, send out a text message, send out an email, whatever I can do with you guys, I'm here for you. I want to make myself as available as possible, even though I'm going to Tucson over Thanksgiving or Christmas. Yeah, Thanksgiving. Over Christmas, I have a whole setup down there now too at my house in Tucson. So I've got a setup here. It's not as nice down in Tucson. This is kind of my major setup. This will eventually probably move to my Tucson house, and I'll put the smaller one up here. But I'm available for you guys. Any questions other than I'll get you your cards? Don't worry, I have a picture of y'all. All right, guys. I hope you enjoyed a little bit. We had a little bit of fun. Like I said, I'm hoping I can come up with a little bit more fun of game. It's just taking a little bit longer than I expected to kind of write it out and come up with an idea on how to do the Trivial Pursuit idea of it. Great, Mike, that's fine. Contact me next week. Contact me whatever you need. Send smoke signals. Yeah, exactly. Right, Justin. All right, guys, enjoy the rest of your night. Get on out of here. I'll remember that. That's fine, Chris. I'll be here. Thanks, guys. Tomorrow I have more like open lab hours, Mike, if you want in the morning. I'll post my schedule as well with this link when I send it, just to remind you. You don't have to attend tomorrow, but he's probably just going to show up to get some extra help. Yep. Contact me if you need. Thank you, guys. Ending session.